how we covered like the 15% rule with Compton and PEs. So I have written down as you increase kVp by 15%, decrease the mass, you decrease patient dose because more is going through the patient and not absorbing it, and then but it creates more occupational dose.
Yeah, your occupational dose is going to go up with increasing kVp because you create more scatter.
Okay, and then if you like do the reverse 50% rule, you increase patient dose and decrease occupation dose.
Yeah, if you decrease kVp and increase mass, then your patient dose is going up. Yeah.
Okay, okay.
Yeah. Thank you. Okay, so just to kind of review what we did on Friday, we talked about kVp and how the interactions change with changes in kVp, which is really kind of what we're talking about. So the factors affecting scatter production would be your kVp, your field size, and your patient thickness. And then we talked about kVp specifically, and we talked about changes in kVp. If the only thing that we change is kVp, we don't change any kind of, make any kind of changes in mass or distance or anything else. The only thing that we change in kVp, there's a direct relationship between kVp and production. Increased kVp, increased production. But it's not directly direct, it's exponentially direct. So that a 15% increase in kVp drastically increases the production, and that goes back to that room spectrum. So where we have the 15% rule is with a change in kVp with an accompanying change in mass. And that's really to maintain the image receptor exposure. All right. So we talked about changes in kVp and how that affects penetration. As kVp goes up, you increase penetration. And therefore, if we increase kVp and decrease mass, then we get a reduction in patient exposure. If the only thing that we do is increase kVp, patient exposure goes up. So in that way, techniques that are better for the patient will be higher kVp, and that's higher kVp. You don't want to shoot everything with 100 kVp, but higher kVp with lower mass is better for patient dose. There's nothing that you can do to compensate for adequate kVp. kVp controls your penetration, and if you don't have adequate kVp to penetrate it, doesn't matter how much mass you throw at it, so nothing can compensate for a lack of penetration. If your mass or your kVp is too low, no amount of mass is going to overcome that. No computer processing. Doesn't matter what you do. It doesn't matter how effective your computer is. If the photons don't get to the image receptor, you just don't have an image. So we talked about kVp and its effect on occupational dose. And occupational dose is going to increase with increased kVp because it creates more scatter radiation. Remembering that what we're talking about is scatter radiation compared to competence. Right, and we took a look at that, and we'll talk about that here in a second again. So the precautions that are best for technologists, well, you can't really reduce your kVp for your dose, so what you do is you use your time, distance, and shielding. You take care of yourself in every way that you can. So how do changes in kVp, or changes in penetration affect scatter? As kVp goes up, penetration goes up, and scatter goes up. And how do they affect contrast? And realistically, they don't. Again, your computer algorithm is what controls your contrast. If you get to a point where you've penetrated everything with equal intensity, then theoretically it could affect your contrast, but you're talking about kVp levels we don't use in diagnostic imaging. So, you know, it really doesn't affect your contrast truly that much at all. Latitude, when we're talking about latitude, we're talking about two different things really. In as much as we're looking at the image, we're talking about contrast and latitude being inversely proportional. High contrast would be low latitude. But we can also talk about latitude as being specific to techniques and adequate techniques to get a good image. What I mean by that is just the word latitude, when you apply it to something, You know, if I say, I'm gonna give you a test, but I'm gonna give you a lot of latitude in how you answer the questions, what am I saying?
More than.
It doesn't matter what you answer, I'm gonna give you credit for it, right? So that's latitude. And in this context, if we have a technique that has high latitude, now I'm not talking about the visual on the image, but the technique has a lot of latitude, that means it's a forgiving technique. If you vary off of that technique just a little bit, you're still gonna get an adequate image. Does that kind of make sense? So in that way, going back to what we were talking about just a minute ago with kVp affecting your penetration, and if you don't have enough kVp to get a good image or any image at all, then a high kVp technique has higher latitude. Does that make sense? It's a more forgiving technique. Higher kVp is a more forgiving technique because if you just botch it just by a little bit, it doesn't really affect the image. Whereas if you're just barely penetrating the patient and then you back off your kVp a little bit, what do you get? You barely penetrated it, and you reduce your kVp. kVp controls penetration, so if you barely penetrated with one technique and then you reduced your kVp just a little bit, then what do you get? No image at all, right? So in that way, high kVp is also high latitude. So we talked about scatter and its effect on density. It is an unwanted density, but just by having scatter doesn't necessarily mean your density is going to go up, right? Because scatter is always present. So we make the mistake of thinking, okay, well, we've got two different patients. One's a big patient, one's a thin patient. The big patient is going to create more scatter radiation. Scatter radiation is a density. It's an unwanted density, but it's a density, and therefore with the same technique, we're going to have more density on the bigger patient. And that's illogical because the patient's going to create more scatter radiation, but they're going to absorb a lot of that. What's left over is primarily going to be scattered. Okay, so don't make that connection between patient size and scatter radiation being density. Therefore, big patients mean high density. Okay, doesn't work that way. So we talked about the best way to control density is with mAs. We've talked about that all semester. So as patient size increases, again, our preferred means of adjusting for patient size would be to utilize the increase in mass. If we have a change in tissue composition, then we might use kVp. You know, we have different types of pathologies that actually increase bony tissue. Osteopetrosis, not to be confused with osteoporosis, which is loss of mineralization in the bones, right? You lose calcium, you lose the phosphorus, all the bony minerals, and the bone gets very radiolucent. Osteopetrosis is the exact opposite. We get much more dense bones. So in those cases, you might increase your kVp, right? But most of the time, it's going to be mass. So what do changes in technique do to patient dose? Well, as you increase either one, without a change, opposite change in the other, your patient dose is always going to go up. Do you have a question or are you stretching?
Sure.
Okay, okay. All right. So everybody with me so far? So we took a look at the different interactions, and again, your Compton is where your dose comes from. So anything that increases Compton increases your dose, providing you're in with the patient. If you're behind that glass is more effective at stopping scatter radiation than what you might think it would be, okay? So we took a look at the difference in photoelectric and Compton with different kVp levels, and what we came to was that as we increase kVp, we increase interactions all the way across the board, right? But what we get, and the reason that we say that with an increase in kVp we get more Comptons is because as we increase kVp, yeah, we get an increase in photoelectrics, but the Comptons increase at such a rate that what we're talking about, the increase in Comptons is the ratio between Comptons and PEs. And we took a look at the numbers, you know, I'm going to raise the board. We took a look at some example numbers. So a 1-to-1 ratio would be where we have exactly the same number of Comptons as what we do photoelectrics. And as kVp goes up, we have a much greater rate of Comptons. You know, if we have 1-to-1 at low kVp, at higher kVp, we may have 1 photoelectric to 5 Comptons. Okay, so in that way, we get an increase in Comptons relative to the photoelectrics. Not necessarily the overall numbers, but the ratio of photoelectrics to Comptons changes. That's what we call the PE ratio, Compton to PE ratio. So we talked about kVp. As we increase kVp, again, we've talked about this all semester, as kVp increases, and that's the only thing that we do, we get much more an increase in numbers emitted from the X-ray tube. We get an increase in the numbers penetrated, and the percent penetrated increases. That's percentage of penetration without any kind of interaction and penetration that are the result of Compton interactions. All right, so again, we talked about kVp and its relationship to frequency and wavelength. As kVp goes up, wavelength decreases, frequency increases. And this was everything we just talked about. Percentage of PEs increases, or the percentage of PEs decreases, the percentage of Compton increases, percentage of transmission increases. As kVp increases, the photoelectrics appear to decrease because of the increase in Comptons. All right, so the effects of kVp, more penetration, we have fewer interactions of all types. I'm sorry, we have more interactions of all types. The Comptons, whoa, this thing is all kinds of messed up. The Comptons, let me get into this and change this real quick. I apologize. We have, with the effects of kVp, we get an increase in penetration. We get an increase of all different types of interactions. The Comptons increase, and the photoelectrics increase less than Comptons. Okay, I'll leave that up for a second. We got it? Okay, so what if you have a large patient? Well, you gotta have enough kVp to penetrate through the patient. Right? So, most of the time, you know, we use a technique chart that is really built into your computer system and into your console. And it's really pretty close to a fixed kVp chart. It may vary a little bit between patient size. For example, you may have presets for a KUB at 80 and 85 kVp. Yeah, 5 kVp is really pretty I won't say insignificant, but it's not all that great of a change in kVp. So, you know, the difference between your average patient at 80 kVp and your hypersthenic patient at 85 kVp, that's not a whole lot of change in kVp. So it's got to be adequate to penetrate. And then after that, we prefer to use mAs to compensate for patient size changes. That's historically, okay? And I think I've mentioned this before. I expect during your career, and this change I think is the wheels are starting to change to turn on this, but I think that during your career what we're going to see is a shift from change in mAs for patient size changes to change in kVp. So I've been saying that for a couple of years, and I think we're starting to see that because on the registry according to the content specs that you guys are supposed to take the registry for, what you don't see in the grid that describes the effects of different technical factors and equipment use on contrast and density, you don't see kVp affecting contrast at all anymore. And that was brand new as of January of this year. So theoretically, if they really get the registry updated, kVp should not be mentioned as an affecting factor for contrast on your exam. I'd recommend you not flush that, because sometimes it takes a while for the test to kind of catch up to the literature. But because of that, I think that in your career, probably in the next 10 years or so, we're going to see a shift from patient size and pathology differences being adjusted for using mAs to kVp. So you get a larger patient, you increase kVp. Now, why would we do that?
So you decrease their dose?
So you decrease their dose, right? If it doesn't make a change in the appearance of the image and possibly interfere with the diagnosis, then there's no benefit really in increasing mAs. Just increasing the mAs would increase the patient dose. Is increasing the kVp going to increase their dose? Yes, it is. But is it going to be as significant as increasing the mAs only? And the answer is no. Okay. So I think it'll probably make that change, possibly within the next 10 years. It may take a little bit longer than that. All right, so with a change in mAs only, then you get a dramatic increase in dose. You can compensate with kVp, but you got to understand that you're going to create more scatter radiation. But there again, if kVp doesn't really affect your contrast the way we've been, the way it has in the past, then there's really no downside to increasing kVp instead of increasing the mAs. So, but again, keep in mind that this might not be on the registry, and it might. So just to be sure that you're prepared for possible questions involving kVp and contrast, the effects of kVp, potential effects of kVp on the image is that it can affect your contrast. So if you increase your kVp, historically, if you increase your kVp, you're going to get a reduction in contrast because you get more scatter. Scatter adds fog. Fog destroys contrast. That's a visibility function, right? So with the increase in kVp, you get less general absorption, you get less differential absorption, and you get more scatter radiation. And that's how it would affect your contrast if you were using films or previous technology. So how would a change in kVp only affect your density or your exposure number? Directly. If you increase your kVp, you're going to get a exposure number that indicates that your exposure to the image receptor increased. So increase in kVp, increase evidence that you increased exposure. And some of your systems, as your exposure goes up, your index number goes down. Some of your systems, as your exposure goes up, your index number goes up as well. So that's why I was kind of non-committal on exactly what it was going to do to it. But you're going to get evidence as kVp goes up. If you don't change your mass, then you're going to get an indication that you've possibly overexposed the patient, certainly increased exposure. So that would be your S number, your index number. So what do changes in kVp do to your sharpness of recorded detail? We kind of talked about this on Friday as well. Sharpness of recorded detail. Doesn't do anything. It's all about visibility because it creates fog, right? Since it creates fog, that's all about visibility. It doesn't do anything at all with sharpness. So just to sum, when you increase kVp, you produce more X-rays, you transmit more X-rays. A lower percentage are absorbed within the patient, right? So what you get is a higher percentage of Comptons, the percentage of photoelectrics relative to your Comptons, that's your PE ratio, decreases, therefore you get a overall increase in scatter. The contrast decreases theoretically. And if you don't have an accompanying change in mass, your exposure will increase, right? So if kVp is the only thing that you change and you increase your kVp, then you're going to get an increase in exposure to the image receptor. Yes.
So you said kVp does not affect SRD, but VRD. Right?
Correct. Right. There's no effect on sharpness or reported detail, just all visibility.
Okay.
So what about mass? What does mass affect? Mass is intensity. Remember, kVp is your penetration, is the quality, and mass is your intensity, or just the numbers of photons that you create. In the X-ray tube, it's just the heat production. It's the number of electrons that you're going to stick around the filament. So going all the way back to electrodynamics from last semester, the more electrons you cram onto something, the more heat you create, right? So MA all by itself is just responsible for heating of the filament. The more electrons you stick on that filament, the more heat you're going to create. So in the X-ray tube, it's heat production, which means that in as much as what's good for the patient is high kVp, what's good for the X-ray tube is what? The main thing that kills the X-ray tube is heat, right? So is high kVp good for the X-ray tube? Or is high mass good for the X-ray tube? What creates more heat? Mass. So higher kVp is actually better for the X-ray tube, right? So in the patient, what mass affects is just directly patient dose. And where kVp, you increase kVp, and that's the only thing that you increase, patient dose goes up, it goes up exponentially. With mass, if you increase mass, you increase patient dose, but it's a direct relationship in every way, right? You double your kVp, and that's the only thing that you do, then your patient dose is going to be just off the charts ridiculous. You double your mass, and you double the patient dose, okay? So it is our controlling factor of patient dose, it's our controlling factor of heat, it is our controlling factor in direct relationship to exposure to the image receptor. It can have a possible effect on sharpness or reported detail in two different ways, actually. One is just the seconds. You know, if your exposure time is too long and the patient can't be still, you're going to have motion artifact. That's all about sharpness or reported detail, right? It's the main thing that destroys your sharpness or reported detail. And you have some control over it, but your patient really has more control over it than you do. So it's not something that you can fully control. So seconds, you know, that's one way, but the other way is blooming. What is blooming? Yeah, where you got too many electrons and the focusing cup can't control or confine those electrons to the focal tract. So with blooming, what you get is a larger actual focal spot, and that gives you a larger effective focal spot, which is all about sharpness or reported detail, right? So in those two ways, the time and the blooming, your mass can actually affect your sharpness or reported detail. Visibility, possible, but only in the extremes. And what that means is that if you shoot with so much mass that you totally flood your image receptor, and think of your image receptor as made up of individual little bitty cups of something, or empty cups really, all right? And those cups are supposed to catch the X-ray photons. And think of the X-ray photons as little bitty balls. So if if you have a different amount of balls in each one of those cups, you get contrast, right? So you've got them filled up to different levels, you've got different levels of contrast, and you can actually make a distinction between different tissue types. But what if you filled every one of them up all the way to the top?
Couldn't tell.
They'd all be the same, right? So in that way, if you overexpose the patient to a point where you fill those image receptors up completely, where they all reach maximum density, the sharpness is still there, but you've got so much density you can't see it. And that applies even to your digital image receptors. So if you overexpose to where, think about your H&D curve, where all of your exposures are in that shoulder section, then you have no contrast, right? And if you have no contrast, you have no visibility or recorded detail. The same can happen if you greatly underexpose the patient and you starve those image receptors. It's not as dramatic. You probably make out an image, but your image is going to be kind of milky looking and just low contrast, and contrast again is your visibility, right? So it can control your visibility, but only in the extreme over or under exposure. In the normal straight line portion of the H&D curve, mass is not going to affect your visibility. Just did that. All right, so kVp versus mass. All right, so changes in kVp. Whenever we change kVp, we talked about that. We affect scatter radiation, but when you change your masses, it affects scatter. Well, it depends on what you consider affects scatter, okay? If you're talking about the number of photons that you create, or the number of photons that are scattered, would it? If you double your mass, would it not double the number of photons scattered? The answer is absolutely it would. But does it change the number of photons absorbed and not scattered? Your photoelectrics, does it change those? The answer is no, it doesn't. So does it change the overall number scattered? Yes, but in this context, what we're talking about is the PE ratio, okay? So the ratio remains the same regardless of what mass you use. The percentage scattered remains the same at low mass as what it does at high mass. The percentage absorbed remains the same at low mass as what it does at high mass, okay? Can you follow me, the difference between those two?
So percentage of scatter remains the same, no matter the mass because of the ratio?
Yeah, because of the Compton to PE ratio remains the same. Mass doesn't affect your Compton to PE ratio. That's all about kVp. Okay? So in that way, mass doesn't really affect scatter. So affects the density. If we change kVp, we talked about that, and we increase kVp, we increase, and again, density equals exposure to the image receptor. So if you increase your kVp, you increase that image receptor exposure. But it's exponential. 15% increase in kVp gives you how much of a change in your image receptor exposure? Double, right? So it's exponential. 15% equals 100%, right? But mass is direct in every way. You double your mass, you double your image receptor exposure. So they go in the same direction, but with kVp, it's a little bit is equal to the same amount that you would have to increase in mass to double, okay? So the effects on sharpness and recorded detail, mass, possible in those two different ways. kVp, none, right? Effects on visibility, kVp is all about visibility because it's all about scatter creation. But mass, only in two extremes. That's extreme overexposure and extreme underexposure. And the effects on dose are both a direct relationship in the same way that exposure does, image receptor exposure. And that is that if you increase your kVp, and that's the only thing that you increase, dose goes up, but it goes up dramatically. If you increase your mass, then dose goes up, and it goes up directly, right? So again, the safer doses for the patient and for the X-ray tube would be higher kVp, lower mass techniques for different reasons. One is with the patient, the dose goes down, increased kVp and decreased mass, the dose goes down because of increased penetration. With the X-ray tube is because the heat production is going to be lower at higher kVp, lower mass techniques. Yes?
You said increased kVp, the dose increases dramatically, and then mass is exponentially?
No, the kVp is exponentially as dramatic. So kVp is both dramatic and exponential. It's dramatic because it's exponential. With mass, it's direct in every way. So if you double your mass, you're going to double your patient dose. With kVp, a 15% increase gives you a double dose. Okay. Everybody good? Okay. So do changes in patient thickness affect X-ray production? And the answer is no. You know, you shoot one patient with 10 mass, 100 kVp, 10 mass, regardless of how big they are, it's the same thing coming out of the X-ray tube in both of those cases. But, and that's when you have a set technique, but what if you're phototiming? How do the phototimers work?
They count the number of photons.
Count the number of photons, right. So you got a patient that's this big and you're doing chest X-ray on them, you got a pediatric patient, and you got one of these corn-fed bubbas that we've got, you know, wandering around East Texas. What's gonna happen when you change the patient size if you do nothing to your machine and you're phototiming though? Okay. It'll what do you mean by it'll overexpose?
It'll shut off later.
Yeah. It won't overexpose the patient or the image receptor. It's just gonna continue to roll. Is that kind of, yeah. The detector is gonna continue to roll until it gets the adequate exposure. Okay, so in that case, if you're phototiming, what happens to the X-ray production? What's happening to what's coming from the tube? It's gonna increase, right. It's gonna increase according to the patient's size and how much radiation they're gonna need, okay? So when you're phototiming, it's automatically going to adjust. You're gonna have an increase in mass whenever you have an increase in patient thickness. All right, so how do changes in patient thickness affect penetration? We have a tendency, again, to make some connections that we need to avoid. And that is, what type of tissue is hardest to penetrate? Bone, right. So by default, what type of tissue is easier to penetrate? Soft tissue, right. So we have a tendency to think, well, we've got this bigger patient, but it's all soft tissue, so it's going to be easy to penetrate. So penetration goes down and scatter production increases, right? And that's why we get an increase in density or increase in scatter gives us an increase in density with the larger patient. Okay, so you got a lot of missteps there. Everything about what I just said is wrong. As you get an increase in patient size, you get an increase in soft tissue most commonly. Yes. You get an increase in scatter radiation creation. Yes. But a lot of that scatter is going to be absorbed inside of the patient. Okay? Now, what comes through the patient and what actually hits the image receptor is going to be primarily scatter radiation, because the increase in patient size was primarily due to soft tissue, right? And soft tissue creates a lot of scatter. That doesn't mean that scatter is going to hit the image receptor and overexpose the image receptor. A lot of that scatter is going to be absorbed inside of the patient. So, as the patient size goes up, even when it's in the presence of soft tissue, then if we don't do anything to our technique, then what's going to happen? The image receptor, what's going to happen to our exposure?
Really not enough.
What's that?
It won't be enough.
It won't be enough, right. We're going to underexpose the patient. So what do we need to change? Yeah, as of right now, the literature says mass. Again, I expect that to change in your career career's time, and it'll probably make a change to kVp. All right, so in that way, patient dose is going to increase. What happens to your occupational dose? You're shooting a chest X-ray, a portable chest X-ray on a patient who's asthenic. You know, you got a nursing home patient, little old lady is just tiny and frail. You shoot a chest X-ray on her, you're not going to create a whole lot of scatter radiation. You get a great big patient, and you're going to create a lot of scatter. You're going to have a big exposure. So it becomes more imperative for you to make sure you wear your lead, get behind the portable. If you're in the department, make sure that you get behind the glass and shoot from behind the control panel. Okay, so as the patient thickness goes up, the potential for you to have a higher occupational dose goes up. What if you're fluoroing? You got to be in a room when you're fluoroing? Most of the time, right? So what are you going to do? That's number one. Wear lead. What's that? Step back. Get behind somebody, right? You know, remember, you're not making all this money in clinicals, you know, to get exposed, right? Yeah, you're getting rich off clinicals, right? So stand behind somebody who's getting paid for it, if you can. Don't make it obvious, you know, because that's just annoying. But, you know, if you can subtly kind of step behind somebody, yeah, do it. All right, so changes in patient thickness affect scatter production. Those photons, if we have an increase in thickness, we just talked about that, they're more likely to be absorbed inside of the patient. What does come through the patient is more likely to be scattered, and that's why it is that we say that with a increase in patient thickness, we get an increase in scatter production. It's not that all those are going to come through the patient, but what is going to come through the patient is primarily going to be scatter radiation. Okay. So what that means to image receptor exposure is, again, with the increase in patient size, your image receptor exposure is going to decrease, providing you haven't changed anything, right? So if you shoot with the same technique, your image receptor is going to decrease. But if you phototime them, which is going to be the case in most cases, then what? What should, as long as your phototimer is working right, what should your image receptor be, exposure be, between your asthenic and your hypersthenic patient? Relatively the same, right? Okay. So what are the options for compensating for changes in thickness? We talked about that. kVp or mass predominantly. So the possibility that increasing kVp is going to affect your image quality is there, right? Because with the increase in kVp, you get an increase in scatter production, you get an increase in scatter penetration, and therefore you have the possibility of a reduction in contrast. Not really, but okay, we'll say that. So kVp could potentially do that, and it certainly did that with screens and films. We just don't see it a whole lot anymore with CR and DR, the computer processing. So, you know, we just don't see it. I'll get back to this here in a second. So how does scatter affect contrast? We've beaten that to death. Scatter affect density, well, it depends. Did we increase our technique? It is a layer of density, but scatter all by itself just doesn't affect the density really all that much. So, with a change in kVp, if you select kVp, as of the literature right now, and I really expect this to kind of make a change as well, if you select kVp to compensate for tissue thickness, you're going to create more scatter radiation, right? So we said that there's two different ways to deal with scatter. One was pre-patient. kVp selection is one of those. And the other was post-patient. Well, what are our options to clean up scatter radiation after it goes through the patient? Grid use, right. What are your two choices or your two rules for grid use?
Has to be
Right, it has to be so thick, and the kVp has to be a certain level of kVp. That thickness is 10 centimeters, that's roughly knee or shoulder size, and the kVp is 70 kVp. So if you increase your kVp, you could potentially increase it to a point where you previously would not use a grid for this particular exam, but if you increase your kVp and you get above 70 kVp, you create more scattered radiation. That scattered radiation has to be dealt with in the form of a grid. So there's a possibility that if you increase your kVp, you might need to use a grid, okay? Now what does a grid do? Yeah, it cleans up scatter. How does it do that? What's that? By absorbing something, really scatter radiation. What's it made of? Lead, right? So, if you have, if the scatter really didn't increase or decrease your exposure, providing you had a good exposure to begin with, your density was appropriate with the amount of scatter radiation you created, you remove that layer of density, what's the effect on your image? What's that? It increases visibility. Yes, it increases visibility. Without seeing mAs, I can't tell where that came from. But anyway, it increases visibility by getting rid of some of the scatter. But what does it do to your image receptor exposure by removing that scatter? It goes down, right? Right. Goes down pretty dramatically. The one problem with using a grid is that it removes a lot of the density. It may be unwanted density, but it still removes the density. So what do you have to do? You have to increase your technique. So your grid factors, how much of a change that you need to make in your technique according to the grid, and we'll talk about that probably Friday, is proportional to how much lead is in that grid. Okay, and they start at around, for decent grids, around 3 to 1, which means that if you use an 8 to 1 grid, you need to increase your technique by a factor of 3, right? So you need to increase your mass by a factor of 3. So if you increase your kVp to lower patient dose, but then it causes you to need to utilize a grid, yeah, you're going to increase it again. You're going to increase it pretty dramatically. Okay, so you got to be real careful with increases in kVp to compensate for patient thickness. If it causes you to need a grid, then you're probably not doing the patient any kind of favors at all. All right, so as tissue thickness goes up, patient dose is going to go up. The scatter radiation increases, so contrast decreases, grayscale increases. Density, again, we're going to assume that the density is adequate, so the presence of scatter just adds to that density. It is a portion of that density, so it's kind of a wash. It doesn't really do anything. Sharpness of reported detail. Can patient thickness affect sharpness of reported detail? How? Because all of this is really visibility, but how might it affect sharpness of reported detail? Okay, motion. If the patient is so thick that it causes your exposure time to be too long, yeah, it could. It wasn't what I was thinking of, but that was a good answer. OID, bingo, exactly. So you got a, asthenic patient, really, really thin. How far can the object possibly be from the image receptor as opposed to somebody who's hypersthenic, right? So OID, right? So primarily it's going to be a visibility issue, but it can be a sharpness issue depending on what tissue type we're looking at. If we're looking at or where the anatomy is inside of the tissue, I guess is a better explanation of that. So can affect sharpness, absolutely affects visibility as patient thickness increases. So again, according to the literature right now, what we need to compensate, what we need to use to compensate for changes in thickness. Thickness is the only issue, is mass. All right, so what we're gonna look at next is gonna be field size, and we'll get through a little portion of this, but we're almost out of time. So changes in field size, do they necessitate changes in X-ray production? Is one question, and subset of that question is what technical factors should we use, and that's kind of a hint to the answer to the first question in that. Do changes in field size affect penetration? How do they affect patient dose? How do they affect occupational dose? How do changes in field size affect scatter radiation, which really kind of goes up to both of the first two? What are the options for limiting field size? Does scatter affect image contrast, and does scatter affect image receptor exposure? Are all the things we're going to look at next. So beam limitation is just that. It is your collimation. That's what you're most familiar with in beam limitation. It's collimation, it's field size. All right, so keep in mind that the wording seems to be inversely related. So as you increase collimation, that means to make your field size smaller. Increase collimation, smaller field size. So between these two, that would be the one with the increased collimation. Now, when we increase our collimation, what we do is we expose the tissue to less radiation, right? So in our interactions inside of the patient, if we open our field size up, we decrease our collimation, we open it up, then we've got all those interactions occurring all the way across the image, right? But as we narrow it down, what we're doing is we're creating fewer penetration, we're creating fewer scatter photons, and even lower in patient dose, because photoelectrics that would be occurring out here aren't occurring in this one, okay? So we're gonna get less interactions with all three primary types of interactions with increased collimation. So field size gets smaller, we get fewer interactions. All right, so the purpose for beam restriction and collimation, if you remember, all the way back to last semester, it was all about dose. The dentist, Rollins, he put lead inside of strips of leather, and he used that in dentistry to reduce patient dose. Instead of blasting the patient's whole head, it was just a small area on the head to reduce patient dose. What we saw in screens and films, again, is an increase in image quality, because when we're talking about image quality, again, we're talking about our contrast density, our sharpness to recorded detail, and our visibility to recorded detail. All right, so back to this graphic. If we opened our collimation and everything that was beyond this point was a photoelectric interaction, we magically could control that. All of this out here was photoelectric interaction. Would it affect our image at all? The answer is no. All of those would be absorbed inside of the patient. This is a hypothetical situation. All of those being absorbed inside of the patient wouldn't affect our image at all, right? If every one of them was a scattered photon, would that affect our image? Yes, it would. How would it affect our image? Would our image quality increase or decrease? It would decrease, right? So thinking about our Compton to PE ratio, we got a patient. What are most of the photons that are going to come through the patient going to be?
PEs.
What's that?
PEs.
PEs stop inside of the patient. That's photoelectric, that's what stops inside of the patient. Most of them, there's going to be some penetration, that's probably what you were thinking of, penetration. There's going to be some penetration, right? But what are most of them going to be? Somebody that thick especially is going to be Compton, right? So we increase our field size, and we're going to get more Comptons striking the image receptor. What do Comptons do to our image quality? It decreases image quality because it increases fog, right? So secondarily to patient dose, with the introduction of beam restriction, we've got an increase in beam or image quality. So we've got a number of different types. What you're most familiar with are your collimators. And we talked about, and I think it was in the last section, that your collimators are actually two sets of collimators. And one set of collimators are the 4 shutters that you see, but you've also got another set of collimators on top of the collimator housing, and that was that multi-leaf thing that we talked about. You remember talking about that? And that was to limit the off-focus radiation, right? Now, PBLs are not something that you're probably seeing all that much, but you still kind of see it in test questions. PBL stands for positive beam limitation. And back in the 60s, 70s, there was a tendency to not collimate a whole lot, right? So what we wound up with is overexposure of the patient. Your collimators primarily are to reduce patient dose, and if you don't collimate, you overexpose the patient, right? So positive beam limitation was automatic collimation. You took a film, an X-ray film inside of a cassette, and you put it inside of the tray of the Bucky, and a Bucky had detectors in it so that whenever you closed the Bucky tray, it detected the size of the image receptor you were using, and it automatically collimated your field to the size of that image receptor that's inside the Bucky. That's positive beam limitation. It's just automatic collimation. The reason you don't see it anymore is because how many different image receptor sizes do you see in clinicals now? One, right? Just one. So it doesn't really apply anymore, but it was law for a number of years that any time that you were bought a new piece of equipment that it had to have positive beam limitation in it. So that was to keep from overexposing the patient. Aperture diaphragms are really what Rollins used. Aperture diaphragms are just a static collimator where it may be a lead piece of material with a hole inside of it mounted on a piece of aluminum that you could put on the collimator housing, okay? So it's collimation, essentially, but you couldn't adjust it, can't adjust it. Probably don't see those all that much anymore. Probably don't see cylinder cones all that much anymore. The cylinder cones are kind of like 3-dimensional collimators, so that they may extend, that's what you would call a extension cone, but they attach to the collimator housing and they stick out away from it a little bit. They were great for doing sinuses. Since we just came through sinuses, they were great for doing sinuses because you could put this extension cone on your collimator housing and you could extend it all the way up to the patient's skin level. And so you had, collimators that were this deep that, you'd have no off-focus radiation whatsoever coming through that collimator, through that cylinder cone. Don't see those much anymore, Those have kind of become extinct, so primarily what you use to restrict your beam is going to be collimators. That's variable aperture diaphragm. Okay? Any questions? Okay, so our test is on the 28th. I might have to record a little bit just to make sure that we can get through. Is that right? Our test is on the 28th?
Yes.
Yeah, I moved it from the 30th to the 28th, so I might have to record some. We need to spend time on grids and grid ratio and different types of grids. So I may record the rest of field size and post it online, and that way we can make sure we have time to spend on grids. Good luck on your test. What's this one over?